Hi, I'm Dr. Rolando Toyos. I'm an ophthalmologist. I have practices in Tennessee, Mississippi, and New York City. I do cataract and refractive surgery, and I'm also a dry eye specialist. What I'm starting to realize is dry eye is becoming an epidemic, and dry eye affects the ocular surface. All the surgeries that we do affect the ocular surface. So if you look, I'm starting to get teenagers, 20-year-olds, 30-year-olds, 40-year-olds with dry eye disease and ocular surface disease. So this is no longer the disease of an old person. So these patients are coming in for surgery, and if you're not screening for ocular surface disease, what happens is you do perfect surgery, and then the patient comes back and they have a problem with the surgery. So you could be the best surgeon in the world. If you don't treat ocular surface disease before surgery, the patient is not going to have optimum results. So what we're trying to find is ways that we can adequately screen these patients, but be efficient in our clinic. And one of the ways that we've done that is using the Cataract 5M. What we did is a study of about 100 patients that had no symptoms of ocular surface disease, no complaints, never been diagnosed with ocular surface disease, and we put them through a battery of tests using the Cataract 5M. And what we found was there was a correlation in terms of what we saw in the slit lamp in diagnosing ocular surface disease and two tests on the Cataract 5M. And those two tests were the non-invasive tear breakup time and also mybography. So if a patient had a non-invasive tear breakup time of less than 10 seconds, that correlated very well to us diagnosing ocular surface disease and treating them before surgery. Or if they had more than 25% meibomian gland loss, as shown with mybography, that patient also correlated with ocular surface disease when we looked at them on the slit lamp. So why is that important? It means that my techs can put a patient through the Cataract 5M, look for those two signs, and before I even walk into the room, I can see that they have a problem with their ocular surface and that I'm going to have a conversation with them that we are going to treat them. And so that saves me time. And what I found with patients is they appreciate the fact that we're actually screening for this, because when they Google these procedures, the first thing that pops up as an adverse event is dry eye disease. So if you're not screening for this and they're doing their little Google search for their surgery, they're seeing this thing and they're coming back to you and going, "Oh, doctor, I heard about dry eye with this refractive procedure," or "I heard about dry eye with a premium IOL. Is this something you're looking for?" And you can honestly say, "Look, we looked for it, we did the test, and we're screening for it." So the tests that I find most predictive and that I'm using the most are mybography and non-invasive tear breakup time. Now, I did a study a long time ago where I looked at non-invasive tear breakup time versus fluorescein tear breakup time. There's about a 2-second difference. I think non-invasive tear breakup time is a little bit more sensitive in picking up tear breakup time, about 2 seconds quicker, which isn't a bad thing because now we're screening and we're picking up patients earlier. So with those two tests, I'm able to predict before I even look at these patients at the slit lamp if they have ocular surface disease, and then it changes my conversation with them before we do surgery. So I walk in a room, I've already have these diagnostic tests that are showing me that this patient may have a problem with ocular surface. I look at the slit lamp, and now I've got an objective way of telling if they have dry eye disease, and we can go ahead, have that conversation, get them treated before they have their surgery, and optimize my results.